talk a bit about endomyocardial biopsy and contrast-induced nephropathy, and some little spotters. The basic purpose here is one, to go through the gamut of the equipments that we use, and also try and highlight some points that we as examiners think are important, and we tend to ask you guys. Now, these are the important equipments that we use in the laboratory, and these are going to be important from our point of view. When we talk of sheaths and the vascular access, one of the major things that the people or the examiners tend to ask you is the difference between the Seldinger technique and the modified Seldinger technique, or what we call as the anterior puncture. The difference is pretty clear in the Seldinger technique. As you can see in this picture, you go beyond the posterior wall, and then you withdraw it, and once the blood comes, then you put in the guide wire. Whereas in anterior puncture, you're feeling the vessel very well, and when you abut the anterior wall with the puncturing needle, you can actually feel the pulsations. You just dip it a bit, and once the flow comes, you don't go beyond the posterior wall in this particular axis. This has been important, particularly ever since the coronary the procedures started to come in, because we give heparins and we give other blood thinners, and if you have a posterior puncture too, you may have a greater tendency to bleed. Further down, the difference between, I was telling you the difference between the Seldinger technique and the modified Seldinger, or the anterior puncture. Now, talking of the sheaths, as you're all aware, we have very long sheaths available now, typically up to 90 centimeter sheaths. So we may have a 27 centimeter long sheath, we may have a 40 centimeter long sheath, and we may have a 90 centimeter long sheath. This particular sheath that is shown over here is a very specific type of sheath called the Balkans sheath. We used it a couple of days ago. We had a superficial femoral artery stenosis in which we had to use a crossover sheath. So these sheaths are particularly helpful in the peripheral angioplasties. For a subclavian stenosis, typically, for example, when you're approaching from the femoral side, you need a much longer sheath, a 90 centimeter sheath. So the length of the sheath will largely be all these sheaths will be able to deliver the guide wires and the balloons and the stents that you need to take across in peripheral arteries. Now, talking of catheter, this is the particular definition of catheter, which is a hollow flexible tube for insertion into a body cavity, duct or vessel to allow the passage of fluids or distend a passageway. Catheter was first typically used in urology. The main factors or the main characteristics that we use for determining what guide to choose, they are highlighted here. The size of the catheter, the shape, the length, the side holes, and of course the sheath that we talked about. The basic reasons why we why we use these guide catheters, the role of the guide catheters is highlighted here. We also know that sizing of the catheters is done based on their outside diameter in French, and the typical internal diameters of each French size, they are highlighted over here. So a 6 French catheter will have an outer diameter of approximately 1.98 millimeters, and these are the typical outside diameters and of different French size catheters. Now, one important thing that people are very fond of asking is what is the primary curve and what is the secondary curve of a given catheter. We've already seen a very detailed exposition about angiography, and the tip of the catheter which engages the coronary is essentially the primary curve. The curve closest to that is the primary curve, and the next curve which stabilizes the catheter to the opposite side of the aorta, opposite wall of the aorta, that is the secondary curve. Another important point to remember is that in diagnostic catheters, whatever may be the size of the catheter, say even up to a 7 French catheter, the tip of the catheter tapers down to a 5 French size. The size of the catheter, that's another important thing. How do you say this is a Judkins 3.5, or how do you say this is a JL4 catheter or a JR5 catheter? So that sizing of that catheter is done by the primary, the distance between the primary and the secondary curves. So that is the factor which determines the size of the curve. That is another important point to remember. So you have these typical Judkins left and right catheter. These we use every day. And we also see the primary and the secondary curve. Now, we also have the guiding catheters or the guide catheters. So what is the basic difference between a diagnostic catheter and a guide catheter? As you can see in this, the diagnostic catheters in blue, they have a smaller inner lumen for the same size. So the guide catheters are, they have a bigger lumen, and there is a difference in the structure. As you can see in this picture at the bottom, you can see that there is a stainless steel braiding between the inner and the outer jackets of the catheter, and that is not there in the guiding catheters. So diagnostic versus guide catheters, what are the differences? One is that the shaft of the guide catheter is stiffer. The guide catheters have larger internal diameter, and they are shorter and more angulated tips. And of course, as I said, there is a reinforcement of the construction, because in the middle there is a stainless steel braid which provides support and stiffness to the guide catheters. I mean, what structure makes you decide that you have to use this size guiding catheter? It is basically based on the aortic root size. So if you have a larger aortic root, you will use a bigger size catheter. Now, this actually Dr. Ajay Kirtane also showed. If you find that on your catheter you have this kind of a pressure curve, what is it that you should not do among all these things which have been highlighted here? That is, advance or retract the catheter, or aspirate or inject. The basic important thing is never inject through a damped catheter like this, unless you are extremely certain as to what is happening. There is a flip side to the story. A couple of years ago, I remember Dr. Samuel Matthews had shown a left main angioplasty, wherein he had, he hooked in the guiding catheter, and there was a sudden vessel spasm, as Dr. Ajay showed. And he asked the whole audience, look, the pressure is 70. Should I give this patient nitro or not? And the answer is yes, you should give nitro if you think that this is a vessel spasm that is occurring over there. But never inject if you have a gross dampening of the pressure. What do you do when you have that kind of a waveform? You change the position of the catheter, you check for the transducer, and you may be sure, you need to make sure by aspiration that your lumen is absolutely free. Next, these are the various types of catheters. On the top left, you can see the Judkins left catheters, then the Judkins right catheters, and then you have the extra backup catheters. Starting in the bottom line, you have the typical Emplatz left and the Emplatz right catheter. You have the hockey stick catheter, and you also have the multi-purpose catheter and a single IMA catheter. The guides, they belong to different families, as I just discussed. So this is to recapitulate that once again. You have guides with side holes and those with no side holes. This typically is present or useful in the right coronary cannulation. Many a times we find that as soon as we hook the right coronary catheter, there is a damping because of a proximal obstruction. So in that case, we tend to use catheters with side holes. There are advantages and disadvantages of these. One thing is the advantages that it prevents the damping. The second thing is that it allows additional blood to flow in while you are changing your equipment through the side hole. The blood flow can continue into the coronary artery, so the patient can stay relatively free of angina. The flip side of this is that this is just a false sense of security, because you're actually measuring the aortic root pressure and not the coronary perfusion pressure. But all said and done, in some given cases where you have damping, the presence of these side holes, it helps you in the presence of these side holes, help you in comforting you, giving you whatever that false sense of security that is there, and also in perfusion of the coronary while you're changing the wires. One thing about EMplats, in EMplats, as you can see, the secondary curve, with this arrow you can see that the secondary curve of the EMplats actually rests against the non-coronary posterior aortic cusp. And EMplats in EMplats catheter, it is extremely important to know as to how you disengage. This gives you a lot of extra support as a guide catheter, but what is important is how to disengage the EMplats catheter. And to disengage, you don't need to pull it, because if you pull it, you will cause an ostial dissection. So you need to push the catheter to disengage, and then turn it clockwise or anti-clockwise, and then pull it out. The disengagement of the EMplats catheter is quite important. Then sometimes your guide is not so stable and you need to stabilize the catheter. I will be discussing stabilizing the catheters or supporting the catheters a bit later also. But by and large, these are important techniques. You can put in a buddy wire. You can put in a wire across the same vessel in which the lesion is. You can put a wire in another branch to support the guiding catheter. You can have a choice of a stronger guide. You can use an anchoring balloon, means over the wire you take a balloon, you inflate at low pressure, and you use it as an anchoring balloon. And you can also change the sheath to a supporting one. Dampening of pressure, we just discussed. If there is a fall in diastolic, this is typically called as ventricularization of pressure, and if both systolic and diastolic are damped, then this is a dampened pressure. And as I just discussed, if the second cause, that is the coronary spasm, is the cause for dampening of pressure, then you need to give vasodilators like nitroglycerin in order to get over this. There are other problems with guiding catheters, like untwisting a guide. Sometimes the guide catheters get twisted, so the basic principle lies to be able to pull them down in the broadest possible area. Typically, beyond the branch, beyond the arch of aorta, if you're able to pull it down, then you put in a 035 stiff wire or a 038 stiff wire, and try to rotate it clockwise or anti-clockwise in a bid to get beyond the point of kink. And once your wire is outside the catheter, then you can just pull it out. Another common problem we very often face is that when we hook the right coronary artery, we enter into the conus branch. This is simply because the catheter size is undersized in this case. So use a size bigger than that. Say if you're using a JR 3.5, use a JR 4 in such situations, and you will get over the problem of entering the conus branch repeatedly. Now, as far as the backup support is concerned, sometimes you need a very stable guide which has got a very strong backup support, because each time you take your hardware, the guide tries to come out. So the supports can be passive, active, or balanced. Passive basically means that the shape of the catheter is such that it is supporting your, the guide is supported. The typical example of a passive support is the EMplats that we talked about. You can use the EMplats left or EMplats right, or even sometimes in case of right coronary, you can use the EMplats left. Active support typically means that you deep seat the catheter, as is shown here in the bottom left, bottom right part. For the LED, if you give a little counterclockwise turn, it can engage better, it can deep hook better. And if you give a clockwise turn for the right and for the circumflex, that is a better way to get into a good support. For the coaxial alignment, you need to know whether the anatomy is complex or you've got a tortuosity or need for extra support. If yes, you can use support from the sinus of Valsalva, and you can use extra support which will be from the opposite aortic wall. And if not, no, then you use the standard catheters. So for from sinus of, support from sinus of Valsalva, you typically have the EMplats right and the EMplats left. You also have the hockey stick catheter and the multipurpose catheter. Power guides would be the typical ones that are used are extra backup catheter, the VODA, and the extra backup right. These are the typical extra support catheters. So for left coronary artery disease, typical catheters that we use are Judkins. If the takeoff is very high, we can use an EMplats left, or we can use an extra backup. If there is a short left main, then if there is a short left main, then we should use a left Judkins, and if there is a long left main, then we can use EMplats, or we can use an extra backup. For right coronary interventions, sometimes the right coronary takeoff may be actually dipping down, as is shown in the bottom left. And in that case, you use either a size bigger than what you're using. For example, in a JR 3.5, you use a JR 4, you'll be able to sort it out. Or you use a multipurpose catheter, and that is it. Sometimes there is a deformed, an abnormal takeoff in which the right coronary ostium is looking up, and then the right coronary is coming down. In such, you have specific catheters like the Shepherd's crook catheter, or the EMplats left can also be used in these situations. For coronary anomalies, if you have a coronary artery from the right sinus, typically a left or a right EMplats or a multipurpose catheter is good. Or if you have an anomalous coronary artery originating from the left sinus, then you use an EMplats, a left EMplats, or you use a larger sized Judkins catheter. Now, if you have a saphenous vein graft, unusual positions, you use a multipurpose catheter or an EMplats left catheter. For internal mammary, you have a dedicated catheter called the IMA catheter, and that should be best used. As far as radial is concerned, radial one can go ahead and do the procedures with the standard catheters, that is the Judkins left and right. What is important to remember is that when you approach from the radial, like we are a radial center, so typically whatever size you use in Indian patients for the left or for the right, you should use a size 0.5 smaller than that. So if you use a Judkins 3.5 for a femoral approach, you should use a Judkins 3 for a radial approach. Likewise, if you use a Judkins 4 right coronary catheterization, you should use a Judkins 3.5. Another simple dictum that we follow is that usually the Judkins right has to be chosen 0.5 above the size of the left coronary catheter. Another thing which is very helpful is the use of Ikari catheters, which are shown here. And we also use these quite often, and we find that these support the radial approach much better than the conventional catheters. Now, based on all these, this is the kind of summary slide for the choice of catheters. So if you have a right coronary which is normal in origin and course, you use a Judkins right. If you have an anterior ectopic origin, you use an Amplatz right or a hockey stick. If you have an inferior or superior origin or course, then you use a multi-purpose catheter. Likewise, these are highlighted here. I need not go into details of each one. So what the examiners are fond of sometimes are, they may ask you, what is this? Which catheter is this? This is actually a catheter which is used for the renal angioplasty. So this is a RDC catheter, a 55 centimeters RDC catheter. This is used for renal stenting. There are it's not possible to remember all the types of catheters. This, the one on this left, this is called the Michelson catheter. Somebody told us we were trying to find out bronchial arteries. There was a case of congenital heart disease, and we had to find out bronchopulmonary collaterals. So somebody suggested this catheter, so I brought the picture of this. This is a Cobra catheter. So sometimes your examiner may want to show you a particular shape. If you're lucky enough to have read about it, very good. But I can tell you, you only know about the catheters which you actually use in day-to-day practice, and some other catheters. Now, further down for support, you have these microcatheters, and these are the ones which are available in the market. People use Guidezilla and Guideliner. The differences, the basic difference in the shape can help you to understand as to what is the difference. This is the most typical, microcatheter that we use. The microcatheter types depend from brand to brand, but this is a Terumo microcatheter, which we standardly use in Indian labs. The purpose of using these microcatheters or support catheters is that it increases the force of the wire, and typically a 1 gram catheter, 1 gram tip load, can increase to 5 grams if you are using a support catheter. There are others like this Tornus. This is a Tornus again by Asahi. The feature of this is that, as you can see, there are spiral grooves in this, and so when you are going through a CTO, you can actually drill a bit through the CTO. That's the main advantage of this, and also because it has got a tapering course, it helps you to drill across the lesion along with the wire tip. You have similarly Corsair. These are some of the American support catheters. I could get the picture. I have never seen them. These are the Turnpike catheters, and Turnpike also has some catheters which are similar to Corsair and Tornus. So these are other typical catheters which are available. Another important group of catheters that are now available is what are called as the dual lumen access catheters. Typically, there are situations like no flow situation. So if you have these catheters, you can take them across, and you can go over the wire through one of the lumens, and through the other lumen you can actually inject. You can also use them in case you are approaching a bifurcation, and through the other lumen you can go across the bifurcation. So this is a twin pass catheter. This is again an American set of microcatheter family. These are, just for the record, these are Mamba catheters. Now talking about the PTCA balloons, the perfusion balloons are no longer available. So you have typically the OTWs, or the over-the-wire balloons, and the rapid exchange balloons, or the monorail balloons that we use usually. The cutting balloons and the scoring balloons like the angiosculpt, they are particularly used in very hard fibrotic lesions or calcified lesions to be able to, they cut through the lesion, so they decrease the chances of dissection. They give a more predictable expansion of the lesion. This is typically what is an over-the-wire balloon. So you need to use a long wire. The guide wire that you use has to be a 300 centimeters or a 260 centimeters wire. And over this, through one lumen, you enter through the guide wire. And this is a very supporting balloon, because the entire length of the balloon is over the guide wire. So in terms of support, The OTW balloon is, in terms of support and penetration power, it's extremely good. But the limitations of this are that you cannot detect the tip because it doesn't have a radio opaque tip, and also the contrast injection is not possible because you've got a wire there. Of course, you can pull out the wire and then you can give the contrast injection at the tip. This is not a coronary catheter, this is another catheter. This is a Berman catheter. A Berman catheter is used for right ventricular injection. As you can see in this, the balloon is at the tip and the holes are prior to the balloon. So when you inject, you are going to inject in the RV cavity and not cause problems. This is a very familiar thing, a rota burr. Further, the guide wires have, they have a core and they have a tip. The guide wires have been classified on the basis of core material, diameter, and whether they taper or not. They've also been based on the basis of their covers and coatings, which may be PTFE or polymer coating, PTFE or polymer covers, coatings which may be hydrophilic or hydrophobic. And based upon how they taper, that also helps. So these are the various factors or criteria on the basis of which the guide wires have been categorized. The guide wires, most of us try to be familiar with one particular set of guide wires, and the guide wire that you use in mostly more than 70% of your cases are typically called your workhorse wires. The wires will depend upon the core material, which will give you flexibility or support and tracking, and also the tapers, which will determine whether your wire will be able to track or not. Ultimately, if you look at the guide wires, two things are important. One thing most important is the tactile feedback, and that will depend upon the lubricity and certain other features which are highlighted here, particularly the hydrophilic or the hydrophobic coating, or no coating at all, which will increase your tactile feedback. Basic principles in wires are that you should try and familiarize yourself with a group of wires rather than trying to do everything. So these are some typical wires that we use: Fielder XT, Confianza Pro. This is like a large number of wires put up in one particular slide, and as we see, you have a set of wires which are workhorse wires. There are wires which support you a lot, like the Grand Slam and the Ironman wire. You have polymer wires which will just wisp through any tortuous lesion. You have CTO wires which include very stiff wires or tapered wires. Two or three things more. This picture I could get from a very old journal. This is the typical tip of Kono's bioptome, or King's bioptome as they were called. And this question says, what are the two best indications of endomyocardial biopsy? Besides graft rejection, the two main indications are if you have a new onset of heart failure within 2 weeks, or within two weeks to 3 months with a dilated left ventricle or new onset ventricular arrhythmias or heart blocks. These are the two major indications why you should do a endomyocardial biopsy. Talking about contrast-induced nephropathy, it is defined as an increase in serum creatinine by more than 25%, or an absolute increase of 0.5 milligrams per deciliter within 3 days. We need to understand that typically the contrast-induced nephropathy occurs after 48 hours. It occurs typically at 48 to 72 hours. It doesn't occur immediately. The main thing is that the main route of elimination of contrast media is the kidney. And what it does is it decreases the vasodilatory agents and increases the vasoconstrictor agents. And it also causes osmotic diuresis. So those are the major reasons why contrast-induced nephropathy occurs. Contrast-induced nephropathy is more likely to happen if the eGFR of a given patient is less than 45. If the patient has normal renal functions, they are able to tolerate a larger amount of contrast. But if they are not, and plus if they have risk factors like diabetes, dehydration, congestive heart failure, age more than 70, or co-administration of nephrotoxic drugs, then this problem gets highlighted. For prevention, do we volume expand? The answer is yes. Do we use a low osmolar or an isoosmolar contrast? Plus minus answer. Should we do prophylactic hemodialysis? The answer is no. The only thing is, if patient actually goes into contrast-induced nephropathy, then sometimes they may need hemodialysis. Now, the best handling of contrast-induced nephropathy is to prevent it. Two things are important. One is hydrate these patients well. And the second thing is always calculate the EGFR. Please learn and also teach your residents to calculate the EGFRs. They are available on apps. Use a CKD EPI method. There are several methods to calculate the EGFR. Use a CKD EPI method to calculate the EGFR. Multiply the EGFR by a value of 3.75, and that is the total amount of dye that you can give to the patient. This is a European Society of Cardiology Class 1 recommendation. For hydration, so there are several controversies in this area. To use the NAC or not, well, N-acetylcysteine is no good. We do continue to give it, but it is in studies that have been done, it has not been found to be useful. Should we use sodium bicarbonate or normal saline? Most comparative studies have shown that normal saline is still the best possible drug. We need to stop nephrotoxic drugs. If possible, even drugs like metformin that our diabetic patients are on. Should we use a low osmolar or a isoosmolar contrast? Again, there are no differences. The major difference is, the major determining factor is the amount of dye you use. So calculate EGFR, multiply it by 3.75, calculate the dose of the dye, and that's how you go about it. I thank you for your kind attention.